Brown, one of our own, Lisa Brown, is going to present today. She's going to answer that question that all your friends and neighbors are always asking you, particularly the medical students in the audience. I have reflux. Is that bad for me? Should I just keep taking these off the shelf, over-the-counter antacids, and will everything be okay? When does that turn into cancer? If it is cancer, what do you do about it? All that's going to be answered in the next 45 minutes.
And then some.
Yeah, and then some.
Okay, thanks for the introduction. It's true. I have had patients come to my office and say, nobody told me I had precancer cells in my esophagus. What are you going to do about it? So it's a big deal. It's a hot topic right now, and everyone's on a PPI. I think it's probably second only to statins. And in terms of PPI use, we know there are long-term effects now. There are epidemiologic studies showing that patients have dementia. People have chronic kidney injury. So nothing is not, without risk. So I'm going to talk to you about Barrett's esophagus and the risk of esophageal cancer. And one thing I want to emphasize to the trainees is, this may not be a flashy, how do we do esophagectomy talk. This is important because you get a large dose of operating room experience and postoperative management, but what you don't get is a lot of ownership over the disease processes until you get out and you're looking at the patient in the office who's asking you all these questions. So it's important in your subspecialty to take ownership over the disease processes you treat and also the ones that are precursors to the diseases you treat, like esophageal cancer. And more importantly, you got to keep pace with the subspecialists in other fields. So you have to be able to talk the talk and walk the walk with the gastroenterologist, okay? So how do we diagnose it? Okay, couple criteria. Endoscopic criteria and biopsy. You have to have both. So there has to be at least 1 centimeter of salmon-colored mucosa proximal to the GE junction. And you have to confirm this on a biopsy that shows intestinal metaplasia, okay? It's got to be there. An even better picture, as usual, from the New England Journal of Medicine. They always have the best pictures showing the gastroesophageal junction, which is the most proximal portion of the gastric folds. That needs to be measured. And then also, if the patient does have what looks like Barrett's esophagus endoscopically, you have to take a look at those projections. The squamocolumnar junction will move proximal. You see those projections, they're salmon colored, and they look very, very different from the pale, glossy esophageal mucosa, okay? So you biopsy those areas, and this schematic shows what happens if you biopsy that white dot. Well, you see the normal stratified squamous mucosa, and right next to that is intestinal metaplasia with goblet cells. Okay, that's really critical for the diagnosis because it's the intestinal metaplasia that is the precursor for potential cancer, okay? On the bottom biopsy, you see cardiac mucosa and squamous mucosa. Now, the cardiac mucosa there is abnormal, but in the United States, that's not technically Barrett's esophagus, but in other countries it is. So there are some differences in how we practice, but 2 things, if you take nothing else away from diagnosis. Endoscopic criteria, biopsy confirmation, those 2 have to be present. So how do we classify it? Of course, there's ways to classify this so that we can all be on the same page and stratify patients according to their risk. There's long segment disease, which is greater than or equal to 3 centimeters. Those patients usually have pretty severe reflux and erosive esophagitis. And the short segment folks, many of them actually don't have symptoms at all. They don't have reflux. And so there's a lot of patients walking around out there with short segment Barrett's esophagus that you don't know about until you do an endoscopy for other reasons. We use the PROG criteria to determine the circumferential extent and the maximal extent and to report that out. So what you do is you figure out where the GE junction is on your endoscope, and then you look for displacement of the squamocolumnar junction proximal, and you take the proximal area that has circumferential disease and you subtract the 2. So this is a C3 because the GE junction's at 36. It goes up to 33. And then you take the maximal extent of the Barrett's esophagus, and in this case it's at 29. So it's a C3 M7 is how you would classify this. And again, this is so that everyone's on the same page and speaking the same language when you're treating these patients. So when we biopsy every 2 centimeters of segmental length, or you just do a total of 8 biopsies if it's less than 2 centimeters long, okay? And these are the 4 quadrant biopsies you hear about. Grading. Again, this is important. This is under the pathologist purview, but there is non-dysplastic Barrett's. There's indefinite for dysplasia, which is more common than you think, low-grade dysplasia, and high-grade dysplasia. And this is important because it's pretty subjective. It's inaccurate. It's an area of pathology that is challenging, kind of like interstitial lung disease. These are hard slides to read. So the current American College of Gastroenterology guidelines require that these biopsies of patients with Barrett's and dysplasia have 2 pathologists review them, and one of them has to have a focus in GI pathology. It's that important because it's really going to change how you think about these patients. So why do we get excited about Barrett's? Well, it is a premalignant condition. It's chronic injury from reflux. The mucus-secreting columnar cells come on in and they replace the reflux-damaged esophageal squamous layer. And this is the only known precursor of esophageal adenocarcinoma that we have knowledge of. So we need to be aggressive about understanding it and treating it. A small percentage of patients with Barrett's will develop cancer, so that's the other hard part is since we have such small numbers, and you see this theme throughout the literature I'm going to present to you, that when you got small numbers, it's hard to do a trial and subject one group to treatment of the Barrett's and the other one not, and see if you can actually come up with a difference if not many people progress, okay? And most of these patients, more than 90% of patients in some series with cancer, they have no prior history of Barrett's. So you're not always going to see this progression, kind of like in colon cancer from adenoma, and you see that progression, okay? And it's unclear why some patients progress and others do not, but we do have some knowledge of the risk factors. And this again is a great review from the New England Journal that did a thorough literature search and determined what the risk factors for both Barrett's and esophageal adenocarcinoma were, and they listed them, and you see they're quite similar. But in a nutshell, it's a lot more common, the Barrett's esophagus, in men, but 2 to 3 times more than women. A lot more common in Caucasians, and then also in patients who are obese, especially this intra-abdominal fat distribution. And one of the theories as to why Barrett's and esophageal adenocarcinoma is on the rise is because of this obesity. That's a hypothesis that hasn't been proven yet. Protective factors. I found this interesting because you don't usually come across this. We're always thinking about risk factors, but I think it's as important to think about protective factors. And this H. pylori, the H. pylori infection actually suppresses gastric acid. So, every time someone comes with gastritis and you biopsy the antrum, you test for H. pylori, you treat it, right? That's what we were taught. But, in some ways, it's actually protective for Barrett's. Tall height, don't ask me. I'm at a disadvantage here, so I have no idea what that one's about. But these, whoever did this review did a pretty deep dive into literature. So epidemiology. So Dr. Jerkovich alluded to this. All your friends and relatives and maybe you have reflux. So the prevalence approaches 20% in the United States, which is pretty high. And of those, only about 10 to 15% have Barrett's. But that's a big number if you consider the whole population. The true prevalence in the general population is unknown, okay? Because like I said, the short segment folks, they don't always have reflux. They don't always have symptoms. You have to have an EGD. You have to do a biopsy. So it's not cost effective or not worthwhile to go through and screen all these patients without symptoms, okay? Prevalence estimate using some mathematical modeling and a SEER database is like 5.6%. So it's about what it is. And some say that it's increasing independent of the number of scopes that we're doing. So you have to, whenever you have an increase in disease incidence or prevalence, especially incidence, you have to figure out, is it really an increase in the population from an epidemiologic standpoint, or are you just detecting it better because you have better tools to diagnose it early or to diagnose it in general? So this is where Olmsted County, Minnesota always comes in. They're one of those counties that does these epidemiologic studies, and this was published in a British journal, which is why it's esophagus and not just esophagus. So on your left is a graph showing the increase in incidence from the 60s to the 90s. Impressive data. I mean, 30 years. I don't know if these investigators are just passing the torch as their careers, as they retire, but they're showing that, you know, the number of endoscopies that were done is markedly increased. But then so is the Barrett's esophagus, and that stands for short segment Barrett's esophagus. Okay? So they concluded that, well, you know, we're just doing more endoscopies, so we're finding it more. And then on your right is the incidence of, that's the incidence of adenocarcinoma, and they split up esophageal and GE junction, and that increased as well. And one thing I want to point out is, and I'll talk about this a little bit later, you know, the incidence is low, 0.5 per 100,000 person years, and it increased several fold. So when you review a paper, when you read anything, every single paper you read on esophageal cancer, the author tries to hook you by saying that it's increasing 5-fold, 6-fold, 10-fold over the last X number of years. True, concerning, definitely, but always think about where you're starting from with this 5-fold increase, because a 5-fold increase in lung cancer would be a lot different than a 5-fold increase in esophageal cancer. Just throwing that out there is something to think about. Interestingly, in this study, these patients, there were 64 with esophageal cancer total, and only 21% of those had Barrett's esophagus. And so it's only a third. And then of those 21, only 4 had Barrett's greater than a year prior to the diagnosis of cancer. So not a lot of lead time. The other 17 had Barrett's at the time of the cancer diagnosis. So that's another thing to think about, lead time on the ability to intervene. They took it one step further, I think, as most good epidemiologic studies do, and they showed the percent survival in the patients with the long segment Barrett's esophagus and the expected survival in that population in that county, and interestingly showed that those patients just, you know, not controlled for anything else, with long segment Barrett's had a decreased survival compared to the rest. So probably a, you know, multitude of factors at play there. So what do we do? Okay, I just told you there's a lot of people out there with Barrett's. Not a lot of them progress. You know, what are the guidelines? What are you going to do about this when the patient comes to you and says, you know, I have precancer cells, do I need to be on a surveillance plan? And currently, the endoscopic screening for Barrett's is recommended for patients with chronic GERD and at least one symptom that puts you at risk for esophageal cancer. So male, age greater than or equal to 50, kind of the usual suspects up there. And if there's no Barrett's, well, you don't do any further screening. But if it's non-dysplastic Barrett's, you should screen every 3 to 5 years, okay? This has been a point of controversy for a long time in the literature, even since I was a resident, working with John Inadomi, who's now the chief of GI at University of Washington, who he did a lot of mathematical modeling to try to figure out, is it really cost effective to even do this every 3 to 5 years for the non-dysplastic? Because as I'll show you in a minute, if you have non-dysplastic Barrett's esophagus, your risk per year of adenocarcinoma is 0.1 to 0.3%. So maybe hard to justify from a cost standpoint. But on the flip side, okay, patients with short segment Barrett's esophagus often have no GERD symptoms. Okay, so we're missing people. About 40% of patients with cancer report no history of reflux. So you're probably not going to be scoping those people, and you may be missing them. And less than 10% of patients with esophageal cancer have a prior diagnosis of Barrett's. So we're kind of in this, you feel like you're in a gray zone at times. So again, the non-dysplastics, very, very, very low risk for malignant progression, okay? But yet we still recommend surveillance. I think guidelines are always going to be a little on the conservative side. Every 3 to 5 years. This shows that in patients with reflux, I already mentioned that 10 to 5% have Barrett's, 10 to 15. And then this is important, the low-grade dysplasia progression rate to adenocarcinoma, 0.5%, and high-grade 7%. And I think we've always been on ready alert for patients with high-grade dysplasia, but I'm going to show you some, I think, fairly convincing evidence that even low-grade dysplasia is becoming something that's garnered a lot more attention. So patients may ask you, do proton pump inhibitors and or anti-reflux surgery prevent esophageal cancer? If you do this, will I get cancer? And if you think about, theoretically, gastric acid suppression, what can you do? Well, acid reflux causes chronic esophageal inflammation. Well, we know that PPIs and reflux surgery heals, especially PPIs, heal severe esophagitis, so shouldn't that prevent cancer? Acid causes DNA double-strand breaks. Okay, that's a setup for cancer. If you can suppress the gastric acid, they probably won't be having those changes. Also, acid, really promotes the proliferation of Barrett's esophagus. So what if you get rid of the acid? Could your Barrett's esophagus regress? And will that prevent cancer? So it's not just regression of Barrett's. The end point is, the important endpoint is cancer. And acid stimulates, esophageal secretion of cytokines that might contribute to cancer. And so what if we got rid of all these things? In your mind, you think, well, yes, let's just treat everyone with PPIs, or let's do surgery on everybody. Well, surgery even has even more. It's like a 2-for. Decreases lower esophageal exposure to acid and bile. So if patients feel the acid, that's the symptoms. They don't so much feel the bile, but we know that bile salts are very injurious to the lower esophagus. So what should we do? Well, this is a study that I remember talking about as a resident, and it's a well-done study at University of Washington showing a consecutive series of their patients, and I think it was one of the first to really say, what happens with the Barrett's esophagus after we do laparoscopic anti-reflux surgery? And what they found was that there was complete regression of Barrett's in over half of the patients with short segment, but none of the long segment ones. So you still have to survey these patients. You can't just do the wrap and walk away and say, we're done, because they could still progress, and they may not have regression of their Barrett's. And this is a systematic review, really thorough review of the literature. Wanted to determine, surgery versus medical therapy for these patients. What's the incidence of esophageal cancer? And what's the probability of regression and progression of the Barrett's? So large numbers that they pooled from many studies, and you see most of the patients had no dysplasia. So small numbers of low grade and high grade, which are the ones we are more interested in. Well, this is what they showed. And I think they did a good job of the way that they split it up. If you just look at the overall results, you would think, wow, surgery's a winner. There's a decreased rate of adenocarcinoma compared to medical therapy. But what they did was they took the randomized trials and the case series, and they split them out separately. And when they did that, they showed that, in the case series, yeah, surgery's still a winner. But in the randomized trials and the cohort studies, the higher quality studies, there's no difference. Because the important values over here, the 0.048, there's a difference in the incidence of cancer in the surgical populations and the good studies and the not so good studies. So it's publication bias. So all these surgeons with case series who did the operation, had a low incidence of adenocarcinoma, followed, yeah, you're going to publish that. If you're doing it and your rate's a little bit higher than it should be in the literature, you're not going to publish that. So that's one way to kind of answer the question there. I guess that box will come in handy later. But in terms of progression and regression, this is a busy slide here. But suffice it to say that regression occurs in 15% of surgical patients and 2% of medical patients. Okay? Again, the more important endpoint is cancer. Okay, so does that matter? Well, adenocarcinoma, what you see on the bottom is, 20% of patients with high-grade dysplasia who are treated medically progress. But again, that's only 2 out of 10. So small numbers, high percent. But in the surgical group, you don't see a lot of patients, progressing to adenocarcinoma. This is not level 1 evidence. It's just kind of food for thought. I don't think the randomized trial is ever going to be done to take patients with Barrett's and kind of, randomize them in a way, surgery versus, PPI. But where are we today? So Barrett's esophagus with dysplasia, kind of switching gears, 2 objectives with endoscopic therapy. This is really taking center stage in management of Barrett's especially, and as I'll show you too, even in early stage esophageal cancer. So you want to treat the primary lesion, and then you want to get rid of all the remaining Barrett's. That's what the goal should be. There's different modalities. Photodynamic therapy is on the way out, has a lot of problems with it. But RFA is definitely front and center. You eliminate the mucosal tissue, Multiple treatments are needed. You do it every 2 or 3 months. You get rid of all the Barretts. And when you do just one RFA treatment, the risk of stricture is 6%, but the majority of those patients are treated with just one esophageal dilation, and they're good to go. So about 3 treatments over 6 months, and Barrett's gone. Okay, so who do you do that with? Okay, which patients? Well, good studies recently. This one is 2009, a little bit old, but still important. Low-grade and high-grade dysplasia. Of course, if you're going to study RFA, you're going to say who are the high-risk people, high-grade dysplasia. You're going to put them in the study, and low-grade dysplasia. They were thrown in as, maybe an afterthought, but this is what you do. This is the, obviously the squamous mucosa here, what's normal, and you see the Barrett's esophagus creeping up the esophagus there. That's one device. That's the balloon device from Medtronic. They also have several different types of probes to get kind of every angle you could want. And you put it in position, blow up the balloon, and that's what it looks like afterwards. And you let that patient just wait 2 to 3 months. Okay? This is just the schematic showing their consort diagram of how they organize their study. Subgroup with high-grade dysplasia, subgroup with low-grade, sham versus RFA. Important outcomes. I think this is pretty exciting findings that the ablation group is in the dark and the non-ablation group is the control groups in the lower bars. The first one shows complete eradication of Barrett's. So get rid of all the Barrett's at 12 months, gone. Okay, much higher in the ablation group. Getting rid of low-grade dysplasia completely. High percentage gone at 12 months. And complete eradication of high-grade dysplasia, again, gone. Okay. More importantly, among the patients with high-grade dysplasia, almost 20% in the control group and only 2% in the ablation group had progression to esophageal cancer. I mean, that's the endpoint, okay? This is kind of a big study. Well, next study that came along said, okay, that's great. Well, what about low-grade dysplasia? I mean, high-grade dysplasia has always been worrisome. And what about low-grade dysplasia? So they focused specifically on that. This is only a few years ago in JAMA, and they randomized 140 patients to endoscopic surveillance or RFA. Okay, even just as impressive. What you see here is progression to high-grade dysplasia or cancer happened at a much higher rate in the control group. And also, from a cost-effectiveness standpoint, the number needed to treat is very small. So in order to prevent one person with low-grade dysplasia from progressing to high-grade or cancer, you need to do 4 RFAs in other patients, okay? And in order to prevent one progression to cancer, you do about 14 treatments, okay? 14 patients that you treat, which is pretty impressive. And obviously with the RFA, you have much higher rate of complete eradication. And also during follow-up, it's sustainable, so it's long-term. And then they just took it one step further and said, well, what are the risk factors for progression? And it's things that are obvious: circumferential Barrett's esophagus per centimeter, the shorter the time since diagnosis, and also if you've had baseline, if you have a history of Barrett's, okay, prior to being in the study. Well, so we kind of know what to do with. I'm going to get a little bit more into early stage cancer and the high-grade dysplasia in a bit. We know what to do with low-grade dysplasia. We have great data, but with these non-dysplastics that we're surveying every 3 to 5 years, is there a way, instead of just, casting a wide net and treating all these patients the same, is there a way to figure out who, with non-dysplastics, Barrett's, is actually going to progress to some sort of dysplasia? Is there any way? So this is a good study done by a group in Chicago. It was published a couple of years ago, and they analyzed all these risk factors and said who's going to progress and who is not. So 2,500 patients. And they made it useful. So they didn't just take all the risk factors and throw them in a big model and publish it and, for a paper to be printed out and to collect dust. They actually made a score. They made a scoring system. So these were the 5 predictors that actually made sense to put in the model or had the most predictive value, and also their value. So if you have Barrett's esophagus greater than 3 centimeters, you get 2 points. If you're 71 years old, you get a point, and you just add it up And the score actually, was quite predictive. It discriminated between those who are likely to progress and those who are not quite well, to the point where the cutoff was about 3. So if you have a risk score greater than or equal to 3, a 9 times greater risk of progressing from non-dysplastic to dysplasia. And we already know that those are the patients that we're starting to treat endoscopically more, okay? So maybe there's a way to figure out who is going to progress, so you're not doing scopes on all the non-dysplastic patients. So just kind of switching gears, talk a ton about Barrett's and just what do we do about esophageal cancer and where are we right now? And this is the NIH data from SEER showing the new cases and deaths, and this is and the percent survival. So you see that estimated new cases in 2017 was only about 17,000. Okay, not many, but it's a very morbid disease, and if it's detected later or even locally advanced, the therapy can be difficult to withstand. Okay, percent surviving 5 years is still quite low. Just to put it in perspective, it's number 18 on the list of new cases in 2017, new cancer cases. So you've got 1% of all new cancer cases in the U.S. Okay, and here's where I'm just going to put a plug in for lung cancer, because you see it's the second highest number of new cases of cancer, but look at the number of patients that die from lung cancer compared to all these other cancers. Okay, so there's a reason we have lung cancer screening. I don't understand why it's not taken off quite as much across the United States as we thought it was going to, but it's important to catch our diseases that we treat early, okay, because we have a modality to catch these early. We're not quite yet there with esophageal cancer, but we're getting closer. I think we're doing better with this treatment of Barrett's and understanding and detecting and treating it. And just to show you, our patients are older, so the median age of diagnosis is exactly the same as it is for lung cancer at 67. And so our patients are in their 60s and 70s. Again, treatment's hard. Chemotherapy, radiation therapy is difficult. We don't have the agents. Lung cancer has a new drug every 2 months. Esophageal cancer doesn't have that. And esophagectomy is a lot more morbid than doing a lobectomy. And so it would be, and these are older patients. Survival's improving. Mind you, this only goes through 2009. And this is where we get to, what are we doing? We're at a crossroads now in between endoscopic therapy and surgery for esophageal cancer, the very, very, very early stage. Okay, there's a couple options here, and they're very different. So when I was a resident, when I was an intern in 2005, it was everybody with high-grade dysplasia or any esophageal cancer, obviously if they need neoadjuvant, they get it, but gets an esophagectomy. The mentality, that thought is shifting a little bit here. So what we do now, we have EUS, it's great for staging, it's great for T stage, but it's not so great for T1A and T1B. In fact, it's not good for T2 and 0 either. So that's how we do T stage and N stage. But EMR, this endoscopic mucosal resection, where you just basically include the nodule in your resection and you resect with a margin circumferentially around that nodule, is much, much, much better compared to EOS for staging these early guys, and maybe therapeutic, okay? So prospective studies showing that 75 patients with high-grade dysplasia or cancer, EMR led to downgrading in 28% and upgrading in 20%. So it's a really important that you do it right and you get that specimen and the pathologist reads it right, because you've always heard, high-grade dysplasia, oh, there might be cancer in there, we don't know. So that's the crossroads. That's always the million-dollar question: does this patient actually have cancer, and you just had a sampling error? So this is usually nodular. You see a nodule, you EMR it, hands down. There's no question. No one will fault you for that. Risk of lymph node mets with intramucosal cancers is less than 3%. Okay. So once you get into the submucosals, the T1Bs, the risk is 20%, and it's a different story. It's esophagectomy. So what does the NCCN say currently? There's just one set of guidelines, okay? Endoscopic resection of focal nodules, okay? Depth of invasion is important, degree of differentiation, and whether or not there's lymphovascular invasion. And so when you get that report of the EMR, you have to figure out if it was therapeutic or not. It's always diagnostic, but was it therapeutic for that patient sitting in front of you? And the lesion has to be less than 2 centimeters, and usually these are much smaller than that, or they're on the order, or much less than a centimeter. And if the pathology is well or moderately differentiated, the invasion is no deeper than superficial submucosa. I mean, I think even that's a little aggressive. No lymphovascular invasion, and you have clear lateral and deep margins. Technically, you could consider that therapeutic success. So I think one of the best papers out there is from the USC group, and they did a series of their own patients comparing endoscopic therapy and esophagectomy, and they do all the endoscopic therapy, the surgeons, the thoracic surgeons there, and all the esophagectomies for, so they see these patients. So they're, at the get-go, the diagnosis, and they're treating either endoscopically or doing surgery and trying to kind of best funnel these patients to the best treatment. And what they found was that they have high-grade dysplasia patients. You can see there's some in each group, and there's esophagectomy patients, or intramucosal cancers in each group. Some got esophagectomy, some got endoscopic therapy. A lot of factors at play into how those patients got chosen for which therapy. Not the prettiest survival curve, but shows that at 3 years, the overall survival was 94% for both groups. At 3 years, the cancer-free survival was 100% for both groups. And at 5 years, the cancer-free survival was 100% in the endoscopic therapy group and 88% in the esophagectomy group. Okay. The other important thing the survival curve doesn't show you, there were no deaths, but the morbidity of the esophagectomies, their complication rate was 40%, and there were no complications associated with the endoscopic therapy. So they had a very good discussion on how they choose patients. So how do you choose these patients for endoscopic therapy versus esophagectomy? Well, there's tumor factors, esophageal factors, and patient factors. And it's a big discussion. Tumor factors, okay, high-grade dysplasia or intramucosal cancer. There's 2 different entities. Visible lesions were resected with negative deep margins. Okay, what if you have positive lateral margins? NCCN said no go, but can you go back endoscopically? Yes, you can go back endoscopically and do additional therapy, and that may work. You have to be able to get rid of all the Barretts. I mean, this person already showed you that they have Barretts. It progressed. They developed cancer. You got to get rid of the Barretts. And so when you treat when you RFA and do EMR at the same time, you can get a 13% rate of stricture. But that, again, about 1 dilation, and the patient's usually feeling better. Well, what about the esophagus? Is this a long segment patient with like severe reflux esophagitis who, esophagus really isn't worth saving? That's one thing to think about. Are they happy with their current PPI regimen? Is that controlling their symptoms? Are they a reflux for are they candidate for anti-reflux surgery later? Obviously, you would do this later. So if someone has a nodule that gets EMR'd, you analyze the pathology, figure out what you're going to do, and then you survey them very frequently for a year. And then later on, you offer them anti-reflux surgery if they want that. And the patient factor is huge. So what's their insurance? What do they want? What do they prefer? How is this going to weigh in their mind? They have to really understand the pros and cons of each approach. And I've had these conversations, and it's really comparing apples to oranges. You're offering somebody endoscopic therapy versus esophagectomy. That's like a ginormous difference, right, in risks and benefits. So they have to be able to live with the uncertainty of this diagnosis, because maybe the endoscopic therapy didn't get it all and they have to have another therapy. They might go through 3 endoscopic therapies and it may just end up having an esophagectomy anyways. This group tended to say 2 or 3 endoscopic treatments, and if that didn't do the trick, then they would do an esophagectomy. And they have to understand that anti-reflux surgery may be an option once you've gotten rid of all the intestinal metaplasia. So lots of important factors to consider when you're talking to these patients, because this is a big decision. And you'll have some that'll say, well, most patients are not jumping to sign up for an esophagectomy, but there's a peace of mind factor associated with that, provided they can get through the operation safely. That's all I got.
Wonderful, wonderful summary. It reminds me of, I think it probably happened to all of us, a really close friend, fits all those categories. Reflux all the time, head of the pill, I mean, years of doing this, treated by Brand Oschlager actually, fell into all those categories. They would keep asking me, what do you think I should do? What do you think I should do? And keep having these sort of conversations. So I bet that most people in this audience have a family member that's asked them about reflux esophagitis and how to treat it. So thank you. Comments? David, you want to begin with a comment?
Dr. Brett, that was an excellent overview of sort of the current methodology and approach to Barrett's, and it can be sort of a black box clinicians. We operate on a lot of advanced stage or stage 2B, 3 esophageal cancers. I sit down and talk with these patients, and they have reflux symptoms in the past that went away, which probably represented their onset of Barrett's. Obviously screening only identifies a small percentage of the patients who are at risk of esophageal cancer, but it's still screening. What's your take on the adherence to screening guidelines for primary care physicians and other sort of frontline healthcare practitioners? Are we screening the appropriate number of people, or is there, like lung cancer screening, is there a large swath of individuals who qualify for screening but aren't being screened?
Yeah, it's a great question, because our two main cancers are very morbid. The 5-year survival rate is low, but if diagnosed early stage lung cancer, the survival is actually quite good, and also for these intramucosal adenocarcinomas. It's been a challenge. I'm the clinical director of the lung cancer screening program, and even with a New England Journal of Medicine trial, largest trial in the world, the Europeans have tried to do lung cancer screening trials, and 55,000 patients randomized to chest x-ray or low-dose CT scan, and just one low-dose CT scan every year for 3 years, and 20% mortality benefit, and still it's really been hard, challenging to grow the lung cancer screening program here, but we're not alone. Every time we go to our meetings, it's similar institutions, academic institutions, trying to figure out how to get, increase the screening rate for lung cancer. And I think the challenge comes with, and I'm not going to say mammography and colonoscopies and things are easy, but the criteria are simply age. For lung cancer, it's difficult because it's age and pack years, and you got to figure that all out. And then the one step further is a lot of counseling. So we're going to find nodules, and we don't know what's going to happen, or you might need a biopsy, but it might not be cancer, and there's all these gray areas. So Medicare has a lot of important guidelines that I think are really important for patient counseling. But in this era of how the healthcare system is structured, it puts a lot of pressure on primary care doctors. It's just one more thing that they got to tack on to the list of 10 problems that they have to deal with their patients, and sometimes more pressing issues, right? So you're managing their blood pressure, managing their diabetes, and lung cancer screening kind of falls down on the radar, but it's really shown a mortality benefit better than any other cancer. So this one's going to be even harder, way harder, because the incidence is 1% of all new cancer diagnoses. So we don't even have the data. No one's going to do the trial that shows, well, if we endoscopically screen, these patients are, versus not, are going to not get cancer. So I'm not hopeful for that to happen. And even if it did, I think that would be different, because it would be in the hands of the gastroenterologist and or us in terms of doing the procedure. I think it's, for some reason, harder to kind of order that CT scan and do that counseling for.
Other questions, comments? Yes.
As a thoracic surgeon, how early do you want to be involved in this patient's care?
Exceedingly early. So you look at what happens with all the surgical subspecialties, okay? I think it's important that your Venn diagram of your practice overlaps as much as possible, within reason, with your referring physicians or colleagues in subspecialties. So I took an RFA course, and it's important to collaborate and connect with your subspecialties. So the day that I spent watching the RFA by a person who's doing it quite well and has a great practice, and just talking. I was the only surgeon there with the 5 other gastroenterologists that were there just that day, and picking their brain about what their practice pattern is and how they do things. It was invaluable. So if, my goal is to, learn EUS, start doing the EMR, and kind of, take some of that over, because it's important that you understand, okay, I did this procedure, that's where the nodule was, I'm going to talk to the pathologist, this is what I saw, this is what I think, and then you're going to be the one talking to the patient and saying, here are your options. And this is, I think it's important if you can be in at the diagnostic level, and then some of these earlier endoscopic therapies, that's a way to be, because we don't know what's going to happen in the future. What if now somehow T1B becomes amenable to endoscopic therapy, or who knows what? I just think it's important if you can, and if your department and your infrastructure allows, to try to overlap.
Do you find it difficult to get those referrals, or is it something that's ongoing?
You'd have to know how to do it, and so if that's where you can partner with industry, because they sometimes have a heat map of where there's more patients with reflux, or more prescriptions for PPIs, or more smokers for lung cancer, and they can kind of set you up, and you need to kind of reach out to the primary care docs is what you need to do, because once the referrals then go to GI, then that's where they are, okay? So one way to do it, though, is I also have GI referrings out in the community who refer patients like this, but then currently, since I don't do the EMR yet, I refer them to GI here. But if you think about it, it'd be much more efficient. If I just took that patient and said, I'll take care of it from point A to point B, and anything, but it's important that anything that referring from the outside institution, anything that they can do, you send that back. The patient needs a cardiology workup, you send it back to the cardiologist that they have in Reading. You don't take it. So there's, these are things you need to think about when you start your practice, and how to best manage those relationships.
It seems like this is sort of like with the angioplasty with coronary disease, losing your practice. With the very, very small lung cancers, less than 0.5 centimeters, they're going to get SBRT pretty soon instead of lobectomies. And with your Barretts, they're going to get EMR instead of an esophagectomy. So all of the easy cases that cardiothoracic surgeons used to do, that you cured them, you don't get to do those anymore. And so that's just progression of medicine. So that cardiothoracic surgeons, they need to be there for the big, big things, and the other things are getting done by somebody else.
That's an important point. We like the hard cases, but some of the, the nice lobectomies and things are, the trial is on right now with SBRT versus surgery for early stage lung cancer. And so that's why I'm emphasizing to be on the wave of that technology, so that you're not sitting there with not many patients who can have an esophagectomy or lobectomy, and where you need to be on the therapeutic end, the minimally invasive therapeutic end, like the endoscopic end. I think the leader in our field is definitely Jim Lukatich over in Pittsburgh, who promotes, his entire division has kind of taken over. They treat, they do CT-guided biopsies of lung nodules, they do navigational bronch, SBRT, RFA, and then they do all this endoscopic therapy too. And that's a full surgeon actually doing all those procedures. So it's important for us to be there, because otherwise, like I said, these things are going to start to kind of parcel out, and you don't want to lose them.
Lisa, how does RFA work in terms of curing the problem? I ask that because if acid and reflux damages a mucosa, the squamous cell mucosa, and turns it into something that's not normally, why does now destroying the mucosa with a different entity now work?
Well, the thought is you destroy it and it repopulates with normal squamous cells, and then you got to get the acid suppression under control. So that's the thought, is you basically give that patient a clean slate, you wipe it out, but then the second component of that is you really have to, you have to get rid of all of it, but the second part is you have to control the acid suppression. So
is a key, the second part.
Yeah.
Just as a follow-up with that, those who the radiofrequency ablation was not successful in repopulating with normal squamous epithelium in that small subset, do they have a worse prognosis? You know, that small
Yeah.
subset that it didn't repopulate with normal squamous mucosa.
I don't know. I would have to look at the,
It's not very many yet, but I
it's
think
not
there's
many,
Not many.
but those are people to think about.
All right, one last round of applause. Thank you.
Thanks.